maybe we can start. Good morning, good afternoon, good evening, depending where you are. Maybe we can start. Okay. So welcome to this webinar of the Histiocytes Society. I'm Jean-François Emile. I will first present you in a few minutes the Histiocytes Society and present also you some housekeeping aspects, and then we will listen to the speakers. So with the Rare Histiocytes Committee, we decided to present you some overlapping syndrome between histiocytosis and hematologic neoplasm. And I think you will have two great presentation today. Does it work? Sorry, I try to press this. Okay, so first some housekeeping aspects. So your microphone is mute, and it will not be possible for you to speak, but you can ask some questions if you have some technical issues and you want to join us and to join the staff. You can use this device, and then we will see you. But the other participants will not see you, so it's mainly for technical aspects. And if you want to ask more scientific questions to the speakers, and if you want to discuss the presentation and so on, it's better to use this Q&A so that everybody can look at it and we can discuss it. It depends on the number of participants and the number of questions. I hope we will be able to give some responses to all the questions, but sometimes if we don't, we must apologize. If you have too many questions, we may not be able to answer to every question, but we will try anyway. We suggest you to become a member of the Histiocytes Society. The Histiocytes Society is living since many years. And I hope it will be still living for many years, and it's one of the important society which help to improve the way we can treat the patients and we can take care of the patients. Today we will present. We have two presentations. One will be made by Matthias Papo, who is working at Hôpital Pitié-Salpêtrière in Paris, in France. And Matthias is working in internal medicine. He made a work published in 7 years ago, I think, on myeloid neoplasm occurring in Erdheim-Chester Disease, and he updated the data from this time, and I think we have many data since this first paper. And then we will hear about mixed histiocytosis with Eli Diamond, who is working at MSKSSC in New York, in USA, and with Francesco Pegoraro, who is working in Meyer Children's Hospital in Firenze, Italy. Francesco also spent a few time in France, in Paris at Pitié-Salpêtrière too. First, a very short introduction in 2 or 3 slides, I think. So concerning Erdheim-Chester disease, and this is why we wanted to make these 2 presentations. Concerning Erdheim-Chester disease, you see that there is a lot of overlapping aspect. Erdheim-Chester is in blue here, and you see there are some blue overlapping with the Langerhans cell here, and some patients do have Erdheim-Chester and LCH at the same time. Fewer patients do have Erdheim-Chester and Rosai-Dorfman at the same time, and very few have the 3 disease, well, at least histological aspect of the disease at the same time. I think for all these patients, we should consider that, and maybe we could discuss this with the panel, but we should consider that all these patients do have Erdheim-Chester, because the clinical aspect of these patients is mainly Erdheim-Chester, but sometimes we have some histological aspects which are quite different. And this is the first point. Erdheim-Chester patients also sometimes have myeloproliferative neoplasia and myelodysplastic syndrome. So you will listen to Matthias' presentation, and it is not so rare. And among patients with Erdheim-Chester disease, some do not have this clinical or biological aspect of the disease, but still have some clonal hematopoiesis. So we will see this with Matthias' presentation, I think. There are also other histiocytoses which have a frequent association with hematologic neoplasm, and we won't have any time to make presentation on this, but this is just to remind you this. We in collaboration with Hélène Jaffe's group in NIH, we recently showed that in patients with indeterminate DC histiocytosis, there is about between 1/3 and a half of patients who has another hematologic neoplasm, and these patients usually have a worse prognosis, as you see here in the red curve here. And more recently, with the French group and Camille Bigenwald, we also presented a series of patients with malignant histiocytosis. And these patients, about 1/3 of the patients, once again, do have a secondary disease. Most of these patients do have either lymphoma when they are mature cell lymphoma when they are adults, or acute lymphoblastic leukemia for children. So it's not so rare in other histiocytosis to share other hematologic neoplasm. This is mainly for adults, but it also happened with children, and you see that you can have in the same children some typical aspect of LCH with lytic lesion of the here on the skull, and some typical aspect of Rosai-Dorfman disease with cervical lymph nodes. So the children can also have this type of mixed syndrome at the same time. So I won't speak anymore, and I will leave Matthias Papo start his presentation right now.
Yeah, thank you. Okay, thank you very much, Jean-François, for inviting me to speak in this webinar. First of all, I'm going to ask for the audience forgiveness because my English is not very good, but I hope if you don't understand what I say, you will understand my slides. So I'm going to talk about myeloid neoplasms that are associated with Erdheim-Chester disease. It's always good to do a little recap about this disease. I think most of you know it very well, but it's an adult disease who occur in more frequently in middle-aged men, and it's a multi-system disease that can involve almost every organ in the body, with infiltration constituted of mutated histiocytes that harbor mutation along the MAP kinase pathway within the RAF or MEK gene more frequently. And this mutation cannot be targeting with kinase inhibitors, which were initially developed in metastatic melanoma, which are RAF inhibitor and MEK inhibitor, which target this kinase downstream RAF. And these are images of the first treated patients with BRAF inhibitor who had a significant improvement in their osteosclerosis of long bone after only 1 month of treatment, and eventually disappearance of their xanthelasma. So today we're going to talk about myeloid neoplasm. The first study we published was 8 years ago, and we observed from a European American cohort that we had 10% of patients with ECD that have associated myeloid neoplasm. Half of them were chronic myelomonocytic leukemia, and the other half were myeloproliferative neoplasm or myelodysplastic syndromes. At that time, we noticed that there was several mutations in the associated myeloid neoplasm. There was, of course, JAK2, which is the more frequently found mutations in myeloproliferative neoplasm, but also additional mutations that are commonly found in these diseases. So this study, after this study, we performed another. So we did next generation sequencing in the bone marrow of more than 100 patients with ECD. This sequencing targeted genes that are involved in myeloid malignancy, and we found that 42% of ECD patients had additional mutation that can also be called clonal hematopoiesis. So the most frequent mutation was TET2, ASXL1, DNMT3G, and NRAS, which are also the most common mutations found in CMML. And we also suspect that the TET2 mutation, which is a gene that codes for the protein TET2, we involved in epigenetic regulation, occur before the BRAF mutation. Therefore, we suspect, but we have no confirmation that the pathogenesis is this one. There is a background of clonal hematopoiesis in the bone marrow patient with, for example, here a TET2 mutation. Then there is a secondary acquisition of more driver mutations involved in a signaling pathway, such as JAK2, leading on one side to the expression of a myeloproliferative neoplasm, and on the other side, the secondary acquisition of a BRAF mutations leading to an histiocytic disorder. But this is only an hypothesis. And we also had an alert of treatment with kinase inhibitors. This is an example of a case that was published. It was an OCD patient with a BRAF V600E mutation, which had no myeloid neoplasm associated at baseline, who started a BRAF inhibitor for the treatment of his ACD. And after only a few days, started to increase his monocyte count and eventually developed a splenic infarct that led to a CMML diagnostic with a JAK2 mutations. Therefore, vemurafenib was stopped and the monocyte count decreased. So today I'm going to present you the characteristic of a larger cohort of ECD associated with MN, and especially things that weren't described in the first paper, the therapeutic response and the evolutions of the mutation under treatment. So we performed this study in the Pitié-Salpêtrière Hospital in Paris, which is a national reference center for ECD. We included biopsy-proven ECD who had associated myeloid neoplasm according to the World Health Organization criteria. Treatment response was evaluated through two parameters, the PERSIST criteria, which is a TEP scan response used classically in solid tumors, and CRP levels. And we also described the evolution of the myeloid neoplasm under treatment, characterized as progression, which means significant increase of blast cells in the blood marrow, or transformation, more than 20% of blast cell in the bone marrow that define acute leukemia. So we retrieved more than 400 cases of ECD, and among them there was 67 patients with associated myeloid neoplasm, which is 15%, not negligible. Among these patients, half of them had chronic myelomonocytic leukemia, and a quarter had myeloproliferative neoplasm, mostly myelofibrosis in essential thrombocythemia, very rarely polycythemia vera, and another quarter myelodysplastic syndrome. Among patients with no hematological malignancy, we had 87 patients that had additional mutations in the bone marrow, which is 20% of the total cohort. We compared main clinical characteristics of patients with and without myeloid neoplasm, and what we can notice is that they were significantly older, almost 10 years difference of the median age at baseline, and there are more lymphadenopathy, 30% versus 8%. I insist on this characteristic because it's not very common to have lymphadenopathy in ECD. For the other parameters that were statistically different, there was more male, more cardiac manifestation, especially pericardial, more pleural manifestation, more infiltration of the renal fat, and more paniculitis. The myeloid neoplasm at baseline, it's interesting because there was a very low level of proliferative CMML. The vast majority of the patients had a myelodysplastic, myelodysplastic phenotype, which is less severe, and the prognosis score for myelodysplastic syndrome were favorable. So in the hematologic neoplasm associated with ECD were almost never in need for treatment. These are the bar charts resuming all the mutations found in the patient with and without myeloid neoplasm. What we can first see is that there was no difference regarding the mutation in the histiocytic disorder. There was 60% of BRAF mutation and 10% of VAMP2K1 in both groups. What we can notice first is that the genes mutated in ECD with myeloid neoplasm are similar to what is observed in CMML, which is not surprising, with a lot of TET2, I6L1, and RAS mutation. The other thing is that when you have a myeloid neoplasm, you seem to have more frequently RAS gene involved, as there was 12% of patients who had a RAS mutation versus only 4% when you don't have myeloid neoplasm. And the other thing, which is not surprising either, is that you have more DNMT3A mutation when you don't have a myeloid neoplasm. It's because it's a very frequent mutation in general population, and it's the less associated with myeloid neoplasm. And also, we noticed that for each patient, there was more mutations when there was a myeloid neoplasm than when there was not. We described response to treatment, and what we can see is that BRAF and MEK inhibitor do a lot better than interferon alpha, which is not surprising. At PERSIST criteria and persistent criteria include with CRP levels, we had a lot more of partial and complete response at 6 and 12 months. And we looked at the myeloid neoplasm evolution at 6 months. There was a similar progression rate between PEG interferon group and kinase inhibitors, but there was more transformations into acute leukemia in the group treated with PEG interferon alpha, 18% versus 3%. If we looked at overall survival, not surprisingly, we had a poorer overall survival when a myeloid neoplasm was present, with almost 10 years difference of the median overall survival. Then we had only, unfortunately, 19 patients which we had data which we has molecular data in the bone marrow before and during treatment with kinase inhibitors. The median follow-up was 22 months, and we can only say two things. It's that the total mutations, the total number of mutations increased during that time from 68 to 99. And it seems like there was an increase of the variant allele frequency for SRSF2 and RAS, but it was on very small population. So we have a crucial need for larger data, which is a work in progress. So to conclude, there is a large proportion of the myeloid neoplasms that are CMML and less frequently myelodysplastic syndrome or myeloproliferative neoplasm. The patients are older and more frequently with lymphadenopathy. And the myeloid neoplasm is often of favorable prognosis and almost never in need for treatment. There is a better efficacy of kinase inhibitor than interferon alpha for the treatment of ECD. There is similar rate of progression of the myeloid neoplasm, but more transformation with interferon. And there is a lower overall survival in patients with myeloid neoplasm. So to my point of view, there is two things that must be there is two take-home messages. One, you have to be careful for MN in ECD because it's frequent, so you monitor and you careful watch the blood counts, especially in older patients who have lymphadenopathy. And two, BRAF and MEK inhibitors seem effective and safe. There is an ongoing work of all the patients who have additional mutations and no myeloid neoplasm, and we are going to do the exact same experiment. Thank you.
Thank you, Matthias. So I already see your questions. Do you consider transplant? Can you see the questions or anyway, you respond, and everybody in the panel can respond, of course. So do you consider transplant in eligible patients with ECD and
yes, we have considered that for one patient who had a CMMR and who had a major cytopenia attributed to the CMML, but he was old, so he had a lot of ischemic cardiac problems, so we couldn't do it. But when we call hematologists for the associated myeloid neoplasm, they often say, "Oh, there is nothing to treat for more sites, so you treat your ECD and you call us if you have cytopenia problems."
Ben, you had a comment also? I don't know whether you have a microphone now.
No comment for me. So.
Okay.
Okay. The other question is, when should you work up for MN in patient with ECD? I'd say when you have a persistent cytopenia, a monocytosis, even slight, and a thrombocytosis or polycythemia. But anomaly in the blood count.
You mean that bone marrow smear is not systematic for the normal care of these patients?
I think if the blood count is normal, I wouldn't do it.
Okay, and NGS, blood NGS is not systematic too.
Blood NGS can be useful if you have, for example, a slight monocytosis and no further argument for chronic myelomonocytic leukemia, because if you have a specific mutational profile, you can categorize your patient like pre-CMML state, but that's all.
Hello, Karen, you have a question? Yeah.
Hello, yeah, I had a question regarding the patients that had lymphadenopathy. Do you have any information about the cause of that lymphadenopathy? Were any lymph node biopsies done? I've never seen ECD involvement in a lymph node, so I was wondering if that was a myelomonocytic infiltrate or more of a lymphoid hyperplasia.
Yeah, there was no, we don't have data on biopsy, but I'm gonna look at that. But I know that in CMML, it's kind of a specific feature of the disease. Sometimes you can even find extramedullary hematopoiesis when you biopsy a lymphadenopathy, but I can't answer your question. I don't know what is in the lymph node. If it's just reactional tissue or histiocytic infiltration with a specific mutation. I don't know.
So the next work will be to make some needle biopsies.
Yeah.
Okay.
There is another two other questions. Can a patient diagnosed with CMML later develop ECD? The answer is yes.
Yes, there are some group of patients with CMML and huge glioblastoma. And
yes, I didn't say it, but half of the patient had CMML before ECD, and the other half was after. What about in pediatrics? Alors ECD, alors you can ask Francesco Pegoraro. We will talk after me because he's the one who published the largest cohort of pediatric ECD patients. I don't have this data.
Yeah, the number of cases we collected so far, it's about 25 to 30, and there is no such finding in children. It's also true that we don't I think very few of them has received a bone marrow evaluation, and when they had, it's not to look for clonal hematopoiesis such you do in adults. So I think we need a longer follow-up evaluation of this patient to be really able to answer this question.
Matthias, I'm not sure, but in one of your slides about the transformation to acute leukemia, I thought that the combination of you said that the transformation was higher frequency with TNF alpha, but I also had the impression that it was also the case with combined therapy. Is there a bias? Is there that some patients were treated with more actively, or yes, here we see some transformation in patients receiving both combined.
Yeah, I don't know. You think they were severe because they had both? I don't know. I'm gonna look at it. It's a good idea.
So
I don't think it's a lot of patients. I think it's one. And I don't remember who it was.
So right now, when you see a patient with ECD and BRAF mutation, which is the most frequent which is the most frequent mutation in ECD. And if you see abnormal blood count, you ask for bone marrow smears and NGS. And if you see a small NRAS or KRAS clone in the blood, what is your treatment? Do you use BRAF inhibitors as for other patients, or do you directly go to MEK inhibitor?
No, it's a very good question. I will use MEK inhibitors because we do know that BRAF inhibitor induce a paradoxical activation of RAS. So when you have a RAS mutation in the bone marrow, I would prefer MEK inhibitors, but there are no data to support that in this cohort, to support that BRAF inhibitors induce more transformation or more progression than MEK inhibitors.
Eli, do you have a comment on this? Do you?
Yeah, I was going to answer. We sequence the blood for all ECD patients prior to treatment, and if there's JAK mutations, CALR mutations, RAS mutations, even if their ECD is BRAF mutant, we'll give them single agent MEK inhibition or combined BRAF MEK. And we've never seen a worsening of the underlying myeloid process on combined treatment, only on BRAF inhibitor monotherapy.
Okay. Any other comment or questions? So, if it's okay, if you have all other responses, I don't know, Francesco, do you share the screen
Yeah.
Okay, so we're listening to Francesco and Eli.
Can you see it?
Yes, it's okay.
Okay. So thank you to all the steering committee to the invitation to present today, and I'm very happy to do this to share this with Eli. It's not the first time we share a presentation, and it's always been very nice and insightful to share ideas and thoughts with someone of his expertise. So the topic we address is mixed histiocytosis, which is an entity that was first described as a separate entity 10 years ago by the Julien's group. They reported 23 patients. They had, in most cases, harbored the BRAF V600E mutation, and they had biopsy-proven ECD and LCH. In some cases, these two entities were diagnosed as contemporary, and in some cases, ECD followed LCH. They also looked at the presentation of these patients, and they found, and as compared to a cohort of ECD patient and a cohort of LCH patient, and they found that the phenotype of mixed histiocytosis was much more reminiscent of that of ECD as compared to LCH. And they also found that patients with LCH first seemed to have a survival advantage as compared to patient with concomitant disease. Also, although there was really did not look for confounded such as age. And more recently, Jérôme led an effort by the French and US groups, and they identified patients with mixed ECD and RDD. They found 13 patients, which accounted for 3% of their combined cohort. And the specific characteristics of these patients were that they had, in most cases, testicular involvement by RDD, and they often harbored the MAP2K1 mutation. And here again, they had histology features that were consistent with both diseases, even in the same biopsy. At the same time, a different classification, a more comprehensive classification was proposed by Arturo based on a revision of 105 cases, which accounted not only for the classic histology characteristics, but also taking into account therapy-related induced phenotypes, which was more frequent in kids, and single system, which was more spanned towards older ages. And this was until last year, where when these two papers came out, one was led by Eli and was from the US groups, and included 27 patients with mixed histiocytoses, so every entity could be included. And one was from the Italian and French group, led by Augusto and Julien, and which focused only on mixed ECD and LCH. I'm going to show you the clinical presentation of this specific cohort. These were patients that were extracted from a cohort of ECD patient of about 500 ECD patients, and they were 69, and they accounted for around 15% of this cohort. These are their clinical characteristics, which were compared with that of ECD alone. And we can see that the most significant difference are in terms of age. These patients are usually diagnosed with LCH and of course, and also with ECD earlier. They have a more balanced female to male ratio, and they have much more frequent involvement of the CNS, including neurodegeneration of the lungs, of the pituitary and the skin and the lymph nodes, and taken all together, they also have a more frequent multi-system involvement, which means higher number of involved sites and more frequently multi-system, which we defined as more than 4 organs involved. These patients, as was previously reported, they could have these different lesions with different histologies, but they also could share the same histology within the same biopsy. And while in the US, in the US cohort, two-thirds of patients, the diagnosis was asynchronous, and in all these cases, the LCH preceded ECD. In the other cohort, half of patients were asynchronous, and in a few of them, we also found that ECD sometimes was diagnosed before LCH. Not sure if the LCH lesions were already present, but they were diagnosed after ECD. When we look at mutation and we focus on the only mixed ECD and LCH, there is a striking association with the BRAF-V600 mutation that it's confirmed. But when we widen a bit the spectrum of what we look for, and we also go deeper and look in this mutation, we also find different mutation, especially in the more rare phenotypes, which include RDD, and such as MAP2K1, of course, but also KRAS and BRAF, indels, and other MAP2 mutations. And so if we think of the spectrum of ECD, mixed ECD, LCH, we have, of course, very different disease at some point, and which can overlap of sometimes be similar among them. But if we think of the mixed forms, what really comes very strong to your attention is the most striking is that it's most often a multi-system, more multi-system disease, which is more touches more the systems that we described before. So the CNS, the lung, the skin, the pituitary, the lymph nodes, but it's in general it's more widespread. And this is a phenotype that it's also described in children. This is the series of 21 ECD patients with childhood onset disease, and almost half of them have a mixed phenotype. And also in these cases, we clearly see that the same biopsy can share pathology features consistent with both diseases. So this is what we find in the clinical practice, and we more recently we try to have a different approach. So we take a large ECD cohort of almost 700 patients, and we applied a non-supervised clustering model, which at the end gave us as an output a model that chose 3 clusters, and these clusters were the widespread cluster, which is the classic presentation of ECD, so long bone, multisystem disease with long bone, perirenal, peri-aortic, cardiac, and so on. We have another cluster that we call the limited disease, which is reminiscent of the other, but which much less involved organ, and a third cluster we call the MAP cluster, because in this cluster this cluster could recapitulate the clinical findings that were first described by Jérôme. So the association with MAP2K1 mutation, but also association with RDD and testicular involvement, lymph nodal involvement, digestive tract, and large vessels. So we have the clinical observation, but we also have a non-supervised model that confirms what we find in the clinics. And if we go deeper, even deeper, and this is even clearer than what I tried to explain. So the widespread cluster has everything up. The limited cluster is very smoldering disease, and the MAP cluster is basically confirms what's been described by Jérôme 5 years ago. And as I was saying, if we go deeper enough and we do a subclustering analysis of the larger cluster, which is the widespread disease, the stronger cluster that comes up again is the mixed ECD and LCH cluster. And this is again a confirmation that what we see in the clinical practice it's really what's happening, because this is again, it's a really unsupervised bias, unbiased unsupervised model. So we don't choose what's coming up. It's the algorithm that does the work. And of course, we have the clinic, we have the algorithm, and we have the biology. And that helps us explain this phenotype, because if we think the hypothesis where the mutation is acquired in progenitors and which differentiates, and sometimes they give rise to a clear ECD and a clear LCH or a clear RDD phenotype. In some cases, we can have intermediate status where the phenotypes is mixed, and this is this explains what we see clinically. What's the survival of these patients? When we looked at mixed ECD LCH, basically it was very similar to those of ECD alone. And this also when we looked for potential confounded effect of age and gender, although there might also be some effect of treatment in these, and Eli will discuss a bit this later. And the same was also found for the RDD cluster. So no striking difference between these two mixed phenotypes and the ECD alone cohort. And but what we could demonstrate, at least in the mixed ECD and LCH cohort, was that we could define clear predictors of poor survival in this cohort, which were at multivariable analysis and older age at diagnosis, an association of hematologic neoplasms, and here again we go back to what Matthias was discussing before, and more obvious, but the lack of response to 3 or more lines of treatment. And on the other end, the presence of lytic bone lesions was strongly associated with an improved survival. And this, if you go back to the original paper by Julien Baptiste Hervier, it's a confirmation of their finding. Although this is much stronger because it's multivariable analysis, so it takes into account. So if you apply a correction for age and all other confounded, you still have deleted lesions that remains as a predictor factor. It is somehow also reminds of what you see in pediatric LCH. And with these, I can let Eli proceed.
Okay, thank you. Thanks, Francesco. And thanks from me to the organizers for having us and for the opportunity to collaborate with Francesco again. So I'm going to go over what we've seen in these same series about treatment, and then just provide some thoughts from me, kind of maybe sort of pearls or suggestions about evaluation and management of mixed patients. So going back to the sort of initial series from the French group, because this was pretty much prior to the targeted therapy era, the comparison was sort of chemotherapy, conventional therapies to interferon, and what the authors found was that pretty much conventional treatments had very dismal responses. Many patients requiring multiple lines of therapy. There were some partial responses, but I don't think there was a long follow-up, but there wasn't mention of subsequent recurrence. The responses were better in interferon to EC lesions specifically. So I think in this case, interferon was the proverbial glass half full, in that it was not great, but it was certainly preferable to the chemotherapy, sort of more LCH directed treatments. Can you go to the next slide, Francesco? And then in the Italian-French series, in their patients they investigated 126 treatment instances with a very clearly superior response rate to targeted therapies versus conventional treatments in the first line setting or considering any lines. And so, of course, it's much higher, but that 77%, that's not actually as high as we see across the board. And I think one potential explanation is the fact that these patients are enriched for neurologic disease. I think in their cohort and in ours, the treatment failures that have been seen for targeted therapies are often in the nervous system, and we know from the data Francesco presented that these are patients who are enriched for CNS, neurodegenerative, and neurologic disease. And as Francesco mentioned, targeted therapy was found to be negatively associated with treatment failure. And then if you go to the next slide, we pretty much found the same. We saw there were some instances of stable disease with chemotherapy, but then those patients ultimately ended up having their regimens changed, and we found essentially no lasting remissions achieved by conventional treatments in these populations. Our plot from the swimmer's plot at the bottom shows that the midline, the time 0 is initiation of targeted therapy. And you see all the essentially instances of progression prior to the initiation of targeted therapy. And we similarly, in a statistically different way, but we compared response of targeted treatment versus conventional treatment and found a vastly different response rate and instance of progression, odds ratio of progression for conventional treatments. And the instances of progressive disease that we had on targeted therapy were not sort of overt resistance. They were sort of smoldering or progressive neurologic disease that I think has been the observation in these patients. Go to the next slide. So, in terms of evaluation and management, I think we can all agree that for this mixed entity, targeted therapy is what would be preferred. And so I think the non-LCH component treatment-wise is I guess you could say, the least common denominator, that should drive the treatment, the non-LCH component. So then the question is really, how do you not miss that non-LCH part? How do you consider it? How do you sort of factor it into your picture from the beginning? And I think that's something that none of us have really addressed so far. We can't for all cases. I mean, one reason is that there is this latency in many instances from the LCH component to the presentation of the non-LCH component. And then most of these studies, certainly ours, these were mostly patients with biopsy proven aspects of both diseases. I know that the Francesco's, their series, they did have some patients who had sort of classic radiologic findings of ECD on top of proven LCH, but those were not the majority of the cases. So I think there's this other population who have likely mixed disease, presumed mixed disease, who should probably be treated with targeted therapy, even if you have not proven by biopsy both entities to be present. And in our series here, we looked at sort of the distribution of biopsy sites. And these essentially don't differ very much unless you're talking about, sort of perinephric infiltrates, which are obviously going to be more enriched for Erdheim-Chester, but all the other sites, you can pretty much see anything in either. So I'm not sure that your initial biopsy site is going to provide that much wisdom to whether you're dealing with a mixed entity or not. So I think that it ends up being some sort of looser indices of suspicion, which I'll just present some ideas for in the next couple slides. So just one, these are sort of these are our sort of thoughts, not really something that I can prove quantitatively, but one sort of dogma that I think we all know, but is a good thing to remember, is to image the legs, the distal legs, in all cases, because you may find lesions in the distal tibia not captured on a skull to thigh imaging, which will sort of, that I think alone will demonstrate ECD, and then to look for xanthelasmas. I've seen many instances of people with sort of demon, refractory LCH, and so they walk into clinic with these xanthelasmas that have not really been sort of connected to the picture, and I think that's the footprint of their ECD. And this is just one patient that we have with both LCH and non-LCH on the face, who just presented as someone who had been treated with many lines of LCH directed therapy, but ultimately had mixed disease. Next slide, please. So I think times that I consider a mixed entity more strongly are when you have a sort of a typical ECD demographic, which is to say, middle-aged, older male with, who ostensibly LCH alone. That can happen, but it certainly can happen. But there's someone who may be more likely to have a mixed picture, so I look very closely. Any instance where someone has their LCH that just blows through first treatment, doesn't even respond in the first place, I sort of revisit the whole case for whether that patient may have a mixed picture. I've seen some instances, I think, especially sometimes in non-white individuals who have RDD pathology, but the PET looks like an ECD phenotype for all the world, and I consider those patients to be treated like a mixed entity. You have to do a little bit of a dermatologic history for LCH patients. Sometimes they've had something removed in the past. Oh yeah, I had that thing. It was called a xanthoma, and this was a non-LCH in the past, that you only get if you ask whether they've had something removed from their skin. And then if I see like a little perinephric something, a periaortic something that really doesn't have another explanation, I will probably treat those patients as a mixed by virtue of something that's fairly ECD specific on imaging. And then in my experience, patients who their LCH was 10, 15 years ago, these sort of very improbably late relapses, often those relapses are with a mixed picture in my experience when someone has their LCH relapse very, very long after their initial treatment. And then this is always an instance to collaborate with your pathologist that, if they're reviewing an LCH biopsy, but, clinically it feels like a mixed picture, ask them to see whether it's a biphenotypic lesion. Is there any bit of non-LCH in this sample? And just to, alert your pathologist to the whole clinical picture so that they know what they're looking at. And then from our series, our experience is that you do not have to have V600E or a MEK1 mutation to have a mixed entity, that it's more diverse than that. And so, in conclusion, these mixed entities have been very, very well defined in some ways, but I think there's still more to learn about the full clinical spectrum and their prevalence. There's also been insights about mutated precursors and cell of origin, but there's probably more to learn for those aspects as well. I think one thing that has become very clear is that targeted treatments are really needed for these patients. So then the challenge becomes when to sort of suspect it when it's not necessarily clear. And I will stop there and we can have a brief discussion.
Thanks a lot to both of you. You probably see the questions, and maybe you can. It's in the Q&A if you want to. There was a comment of Jorge. Francesco, you want to give some responses to the questions, or?
Sure. I mean, I don't know. I mean, LCH and ECD seem like very different disease entities to me that don't just happen to happen in different ages. Francesco, I don't know if you have any other comment on that from a pediatric point of view. You're muted, sorry. Yeah.
Yeah. I think it's this is or at least to me it's one of the most fascinating aspects of histiocytoses in general, is how we struggle to define them, and at some point we come up with something that we really don't get to define it at the ultimate point, because there is always something that we try to define them based on mutations, and then there is some clinical phenotype that escapes from this definition. We try to define them by clinical phenotype, and we see very similar phenotypes with different mutation, and very similar different phenotypes with the same mutation. And again, we can see very early in we have demonstrated that it's rare, but it exists. ECD is a disease of old age males, but we see them in children even younger than 10 years old, and so I think that to my very limited experience, I am prepared to be surprised by anything in this field. So I take any possible explanation. And just to answer Aisha about childhood ECD, yes, when we looked at the cohort for the first time, we were very aware of the likelihood of the pathologies to prefer xanthogranuloma to ECD. So when we selected these cases, we just included those with a very stringent clinical. Of course, they had to be pathology biopsy proven, but also have very stringent criteria that linked their disease to ECD. So we took long bone, symmetric infiltration, osteosclerosis, perirenal infiltration, bilateral perirenal infiltration, coated aorta, and cardiac infiltration, especially in the right atrium. So that was the way we accounted for this, for the potential misselection of patients. And of course, if we consider just the pathology, it's much more easy to get more LCH patient with some features of xanthomization, as Jean-François would probably call them.
No, I agree that there are still some nosologic questions about when do we say it's still LCH. I'm sharing in the screen here. You see this child with a bone biopsy, and the same samples you see a typical LCH, and you see typical what we could say as pathologists xanthogranuloma, which you can see also in Erdheim-Chester disease. So is it already Erdheim-Chester disease with LCH? As a pathologist, I would say, but the other pathologists will comment, but I would say, well, I just asked to the clinician. This is what I see on the screen, but I just ask you if you think on imaging that it is ECD, even in a 4-year-old boy, because you see the symmetrical involvement of long bones, you see as you say, the perirenal involvement and so on. So you will say it's ECD. Otherwise, I will say, well, it's just an old LCH. But maybe you should be careful and keep on this child and see whether in 10 or 15 years, I don't know, he will not have also an ECD. So we are still learning, I think. But as a pathologist, I cannot say that this is ECD. I cannot say alone that it is a mixed histiocytosis. But we have tumor boards and we have to discuss. So this is my opinion, but please comment.
Gaurav, did you want to?
Yeah, I mean, I think this raises so many important questions and highlights that we really don't know a lot. And so, that's why we do research, I guess. And, one thing that we have to be cognizant of, that this is still reporting epidemiologically cases like this is still it's a biased analysis, right? Because the diagnosis of LCH and ECD is made differently. LCH biopsy diagnosis can be made on path. ECD relies on the clinician to call it. So this may still be an under recognition of the co-occurrence of these phenotypes together. And there's no surprise that LCH occurs before ECD, because the occurrence of ECD is in the eyes of who is seeing the patient. The occurrence could have happened before. So it would be really interesting to see, going after what Arturo has mentioned, is whether especially older LCH, individuals with LCH, especially with BRAF V600E, the ones who are uniformly followed, what are their outcomes like for a long period of time? Because there is a lag. There is a long lag, as you can see, between calling LCH, and I'm going to use the word calling it. So calling it LCH or calling it ECD. And so it will be interesting to see if we uniformly follow a group of LCH individuals, or what we believe to be pure LCH, and see what their outcomes are. Because the BRAF V600E prevalence, Francesco, that you showed, close to 80%, correct, in mixed ECD LCH, is very close to what we reported for just plain ECD with long bone involvement, 76%. So I wonder if this is just sort of different manifestations of what we call as ECD, depending on various factors that we don't know of. And of course, the much more smarter biologists need to figure out what makes the cell go into one phenotype versus the other. But clinically, to me, this is just very fascinating and raises a lot of questions and highlights that we need to be, like Eli pointed out, very carefully monitoring these cases in the clinic, especially with the LCH, because LCH will be diagnosed earlier than ECD. There is no doubt about it. So we have those cases in our clinic, and we should be monitoring them very closely and keeping an eye on these sort of more fibrotic diseases or sclerotic lesions.
Just a final comment to Meenakshi's question. I treat these targeted therapy wise as I would ECD alone. They don't necessarily need combination versus dual, and single agent MEK inhibition is generally works all around. So the mixed entity does not necessarily have me escalate the number of agents. Oh, I'm seeing other questions here.
The new questions appeared. I see. Ben, you have the microphone, or?
No, I don't. I was just commenting. I was just marking the questions being answered live. So I think Arturo's question is the next one, though, or comment. Giving oncogene-induced senescence described in BRAF mutant ECD. Number one, the fact that LCH, especially mixed a risk organ negative, may histologically mature during time into fibroxanthomatous lesions akin to those of ECD, and that the majority of patients present with LCH first or concurrently with ECD. Can mixed histio just being a clinical histological manifestation of BRAF-induced senescence in adult LCH patients? We don't know yet. This would be exactly what once would call Hans-Schüller Christian disease, which kind of comment his question. But again, we've kind of addressed some of that, I think, with the speakers, kind of how the biology is still not very clear between different ECD and LCH. And so we're just starting to really look into the microenvironment of these diseases and how those contribute to the mixed disorders, because we really don't know how the microenvironment, especially in the biopsies where we have LCH present and ECD present in the same biopsy, how's the microenvironment different between in the LCH region of that and the ECD region of that, for example, or JXG region of that, if you have, or xanthogranuloma region of that. We don't really know, since the digital spatial profiling aspect of that, something that still needs to be done in the biological field. And again, LCH is LCH and ECD, when you look at them separately by RNA sequencing, they're very different. They have a very different transcriptomic profile. So I wouldn't say they'd be the same disease, but how they become how mixed arrives, we don't really know yet. That's still a big question in the biology of this disorder. But I agree that there definitely, as people have mentioned, other panelists and the speakers, that this is an area of future research. And any other comments on that, Jean-Francois?
No, I think we are about to finish. So we could discuss a long time, and I hope we will also discuss in Seattle soon. Well, in September, and I hope that's when we will go in Seattle, we will already have some new data, and so because if you have some burning comments or other burning questions, we can continue, but I think we have finished our time, so maybe we could go on. So in Seattle, we will still discuss this and some other points. I think we didn't address more precisely the neurodegenerative aspect of these patients. In your presentation, Francesco, you did not. You spoke about CNS, but not precisely on tumor CNS and neurodegenerative directly. And even in CNS, I don't think it's not exactly the same when it's meningeal involvement, and when it's within the brain parenchyma. I don't think it's the same, because with Rosai-Dorfman, it's quite frequent to see a meningeal involvement, but we don't see neurodegenerative disease, for example. So I think we have to improve in the way we are the neuroradiologists and so on. We have to improve, and in our database probably we have to have these differences. So there are still many points to improve, and I hope it will help to take care of the patients in a better way. So I hope we discuss, and I hope that all of you will come to Seattle at the end of September. there is also a few slides. So you can also see the next webinar. It will be in July, so before Seattle, before we meet in Seattle, and it will be organized by the HLH Steering Committee. If do you want a last comment, Eli? Go back in the desert. Okay.
Thank you. What a great discussion.
Okay.
Thanks for organizing.
Goodbye, and thank you for organization and Histiocyte Society for allowing all this discussion. Thank you very much.
Thank you. Bye.